This is Christopher Whittu, and I'm going to be discussing our chapter on cervical, thoracic, and lumbar stenosis, prepared by Dr. John O'Toole and I. The objectives are to understand the etiology, clinical presentation, diagnosis, and natural history of cervical, thoracic, and lumbar spinal stenosis. We'll then discuss the indications and outcomes of surgical decompression, and we'll highlight areas of controversy in surgical decision-making in the management of spinal stenosis. So to start, we'll focus on cervical spinal stenosis. Cervical spinal stenosis can be broadly dichotomized into congenital and spondylotic, also referred to as degenerative. Congenital stenosis is defined as an anterior-posterior diameter of the cervical spinal canal of less than 11 millimeters. Conversely, spondylotic stenosis is an age-related process that progresses over time as a result of osteoarthritic degeneration, such as uncinate or facet hypertrophy, or osteophytic bone spurs, ligamentous aberrations, such as ossification of the posterior longitudinal ligament or the ligamentum flavum, or structural changes, such as intervertebral disc herniations or spondylolisthesis. In reality, these degenerative processes rarely occur in isolation, and it is typically a combination, which leads to pathological compression of the cervical spinal cord. Patients who present with symptomatic cervical stenosis most often complain of an unsteadiness of gait and declining dexterity of their hand function. On exam, findings of pathological reflexes and a dysfunction in tandem gait are suggestive of upper motor neuron dysfunction associated with cervical spinal cord compression. At more advanced stages, patients may also have objective weakness, particularly of the upper extremities. However, it's essential to recognize that this constellation of symptoms and signs is not exclusive to cervical spinal stenosis, and the differential diagnostic considerations are broad. These include peripheral compressive neuropathies, especially carpal tunnel syndrome, or myriad of inflammatory, infectious, vascular, metabolic, or neoplastic conditions. Consequent upon the broad differential diagnosis, it is imperative that the workup for suspected cervical spinal stenosis include radiographic imaging. The modality of choice is MRI. This serves to rule out alternative causes and to delineate the location and extent of spinal cord compression. MRI imaging of patients with cervical spinal stenosis often reveals intramedullary signal changes of the spinal cord. It's particularly common to find a T2 signal hyperintensity. However, this has also been observed on MR imaging studies of healthy volunteers and has not been shown to be a reliable predictor of progression when symptoms are already present, though it may serve as a marker for increased likelihood of symptom development in those who are asymptomatic. Conversely, T1 signal hypointensity is less common, but it may suggest a greater extent of spinal cord dysfunction, and it has been shown to be a negative prognosticator for improvement following surgical intervention. Other imaging modalities that may be considered are CT and CT myelogram. In general, CT should not be ordered routinely in addition to MR imaging, but may be considered when there is a suspicion of ossification of the posterior longitudinal ligament, which may impact the choice of surgical approach. CT myelogram is an alternative to MR imaging for patients who have contraindication to MRI, such as a pacemaker or a spinal cord stimulator. Plain film X-rays have limited utility in the diagnostic workup of suspected cervical spinal stenosis. Classically, the Torg-Pavlov ratio of the vertebral body to spinal canal was used to identify young athletes with congenital stenosis who were at risk for spinal cord injury. However, this has been shown to be unreliable for patients with degenerative stenosis. Now, plain film X-rays serve primarily to provide information for surgical planning. Neutral lateral X-rays of the cervical spine allow for measurement of alignment parameters such as lordosis, sagittal vertical axis, and T1 slope, while dynamic flexion-extension lateral films serve to identify areas of mobile listheses or segments of fixed kyphotic deformity. Following the diagnosis, the natural history becomes particularly relevant for management of cervical stenosis. Once symptoms of myelopathy are present, it has been found that progression is typical, This may be in a steady fashion or in a stepwise manner, with quiescent periods punctuated by periods of neurological decline. It has been observed that somewhere between 20 to 60% of symptomatic patients will have a neurological decline over 3 to 6 years. In particular, those with circumferential spinal cord compression or symptoms for longer than 5 years are thought to be at greater risk. Those who have a radiologic finding of cervical stenosis with spinal cord compression, but who remain asymptomatic, are thought to have about an 8% risk of developing myelopathy at 1 year and a 23% risk over 44 months of observed follow-up. Notable risk factors include concurrent symptoms of radiculopathy, T2 hyperintensity, or prolonged somatosensory or motor evoked potentials. It should be emphasized that the risk of acute spinal cord injury after a minor trauma in patients with asymptomatic cervical stenosis is likely quite low. However, it is often perceived by physicians to be high and may serve as an unjustified indication for surgical intervention. Traditionally, surgical intervention was viewed as a means to halt symptomatic progression. However, more recently, prospective observational studies have shown that surgery is associated with improved neurological symptoms, disability, and quality of life. This has led to the emergence of guidelines for surgical intervention, published in 2017. For those with moderate or severe myelopathy, surgical intervention is suggested. For those with mild myelopathy, surgery should be offered as a choice. However, non-operative management with supervised rehabilitation, counseling to avoid high-risk activities, and clinical follow-up may be considered. However, if neurological deterioration is observed during this period, surgical intervention should be undertaken. For those who are asymptomatic but have radiographic evidence of cervical spinal stenosis, non-operative management should be the primary consideration. In cases where the clinical onset of myelopathy is observed, these patients should then subsequently be offered surgery. In summary, MR imaging is the radiographic modality of choice in the workup of suspected cervical spinal stenosis. Patients with asymptomatic stenosis should be managed non-operatively with risk counseling and follow-up for neurological change. Patients with mild myelopathy should be offered surgery, but also may consider initial non-operative management with structured rehabilitation, risk counseling, and clinical follow-up. Those with moderate or severe myelopathy should be offered surgery up front. Next, we'll focus on thoracic spinal stenosis. Thoracic spinal stenosis is generally considered to be a degenerative process. The underlying pathological causes are similar to that of cervical stenosis and include osteoarthritic degeneration, ligamentous aberrations, and structural changes. Notably, OPLL is most commonly observed in the upper and middle thirds of the thoracic spine, while intervertebral disc herniations and ossification of the ligamentum flavum are more common in the lower third of the thoracic spine. Patients with thoracic stenosis will often present with a spastic paraparesis of the legs, sensory changes to the trunk and legs, and sphincter dysfunction in more advanced cases. On examination, patients may have leg weakness, pathological reflexes of the lower extremities, instability of gait, and a sensory level that matches to a thoracic spinal dermatome. Overall, the differential diagnosis for thoracic stenosis is broad and is in fact quite similar to that of cervical stenosis. The primary differentiating feature of cervical and thoracic stenosis is the relative sparing of the upper extremities in thoracic stenosis. As with cervical stenosis, the primary imaging modality of choice is MRI. This rules out alternate causes and delineates the location and extent of spinal cord compression. In addition to MRI, patients with symptomatic thoracic spinal stenosis should have a CT at the thoracic spine. This will clearly delineate the extent of bony compression and also identify ligamentous ossification or calcified intervertebral disc herniations. Little prospective data is available in the literature to delineate the true natural history of thoracic spinal stenosis, and this is attributable to the rarity of the condition. In general, the majority of clinical studies show that non-surgical treatment is not effective in patients with thoracic spinal stenosis. Consequently, surgical decompression is typically viewed as the only effective treatment approach in symptomatic cases. The options for approach are multiple, and the specifics will be detailed in other chapters of this book. However, generally speaking, isolated dorsal compression of the spinal cord, most commonly from ossification of the ligamentum flavum, may be treated with a laminectomy alone. For ventral compression, caused by soft disc herniation, a posterior transpedicular approach may be taken. Most often, this only requires a partial removal of the rostral medial aspect of the pedicle, which obviates the need for fusion. For cases of ventral compression from a calcified disc or ossified posterior longitudinal ligament, a more invasive approach may be required. Options include a costotransversectomy or lateral extracavitary approach, or an anterior transthoracic approach. In conclusion, MR imaging is the primary modality of choice for patients with suspected thoracic spinal stenosis. CT imaging should be obtained in any patient with thoracic spinal stenosis and will serve to delineate the extent of bony compression and identify any calcified intervertebral disc herniations or ligamentous ossifications. There's really no evidence to support non-operative management of patients with symptomatic thoracic stenosis. And the options for surgical approach are numerous and should be guided by the nature of the compressive pathology and surgeon familiarity. Finally, we'll conclude our discussion of spinal stenosis with a focus on lumbar stenosis. As with cervical stenosis, lumbar stenosis can be dichotomized into congenital and spondylotic. The pathophysiological classification of spondylotic changes are similar. Neurogenic claudication is the hallmark presenting complaint of those with lumbar spinal stenosis. This is characterized by lower extremity pain, exacerbated by walking, and mitigated by forward flexion or sitting. Most often, the clinical exam will be normal, but in severe cases, weakness and muscle atrophy may be found. The differential diagnosis is broad, but it's imperative to rule out vascular claudication and osteoarthritis of the hip, as these may present in a similar manner to lumbar stenosis. MR imaging is the primary modality of choice. It serves to rule out alternate causes of symptoms and also serves to localize the compressive pathology. This localization can be broken down into three regions: the central canal, the lateral recess where the nerve roots exit from the thecal sac, and the foraminal space bordered by the rostral and caudal pedicles. Overall, the natural history of lumbar spinal stenosis is rather benign. Patients are most likely to remain symptomatic, though a small subset of patients may experience an improvement. Reassuringly, there is a low probability of acute neurological decline. In regards to management, non-surgical modalities are typically considered first. Options are broadly classified as pharmacological, therapy-based, or interventional, such as epidural steroid injections. Currently, there is no consensus on the efficacy of any specific non-operative regime. And despite initial non-operative management, patients will commonly decide to convert to surgery. The SPORT trial data indicated that 43% of patients who were initially randomly assigned to non-operative management had undergone surgery by 2 years. And in another large RCT published more recently, the conversion rate was 57%. The best evidence for the efficacy of surgical intervention for lumbar stenosis comes from the SPORT trial. This prospective randomized controlled trial demonstrated a significant advantage of surgery upon an as-treated comparison of operative and non-operative groups at 2 years, and then again with similar findings at 4 years. Conversely, the intention to treat analysis did not show significance, but was greatly limited by crossover. As mentioned previously, over 40% of patients assigned to non-operative management had converted to surgery by 2 years. The specific surgical technique options for decompression of lumbar stenosis are numerous, but they can generally be thought of as open approaches and minimally invasive approaches. Then in each category, there are techniques suitable for the decompression of central stenosis and other techniques for the decompression of lateral recess or foraminal stenosis. Classically, central stenosis was treated using an open laminectomy through a midline approach. However, this technique can be refined somewhat to limit the decompression to the interspinous and interlaminar region by only resecting bone up to the rostral and caudal insertions of the ligamentum flavum, and then removing the ligamentum flavum as well. The advancement of minimally invasive techniques allows the same decompression to be accomplished through a tubular retractor placed 2 to 3 centimeters off the midline. In regards to lateral recess and foraminal stenosis, a unilateral foraminotomy can be performed with a traditional midline exposure or with a minimally invasive tubular retractor. All of these techniques will be discussed in greater detail in the text of the accompanying chapter. Interspinous process distraction devices gained attention recently. They were reported to potentially eliminate the need for surgical decompression of lumbar stenosis and could instead accomplish the same decompressive effect by distracting the rostral and caudal spinous processes. However, randomized control trials comparing surgical decompression to these devices suggest short-term patient-reported outcomes are the same, but the need for secondary procedures is substantially higher in those with a spinous process distraction device. While the data from the trials on spinous process distraction devices were far from encouraging, the data on laminar stabilization devices, which are designed to be inserted after surgical decompression of lumbar stenosis, are more encouraging. An RCT of surgical decompression versus decompression plus an interlaminar stabilization device showed significantly higher composite clinical success scores in patients with the device inserted. The score was part of an FDA study and included patient-reported disability, secondary surgery or injections, neurologic status, and adverse events. Thus, interlaminar stabilization may serve as a helpful adjunct to surgical decompression in select cases, but further study will be needed before utilization becomes routine. In regards to lumbar stenosis with concurrent segmental spondylolisthesis, the SPORT study again provides the best data on the efficacy of surgery. In the as-treated comparison of surgery versus non-operative management, surgery was found to be associated with significant improvements in patient-reported outcomes out to 2 years. However, while surgery is efficacious, much controversy exists regarding the role of fusion in addition to decompression when there is concurrent low-grade spondylolisthesis. 2 randomized trials published in 2016 produced conflicting results, with one finding significant improvement in the SF-36 physical component scores in those undergoing fusion over a 4-year horizon, and the other finding no significant difference in the Oswald Street Disability Index out to 5 years. Thus, more data will be needed to draw any definitive conclusions on the role of fusion for lumbar stenosis and concurrent spondylolisthesis. To add further to the controversy, it has been shown that interlaminar stabilization devices may mitigate the need for fusion. In a non-inferiority analysis, patients with lumbar stenosis and a low-grade spondylolisthesis who had a decompression and interlaminar device performed similarly to those who had a decompression and fusion. This may present an opportunity for cost savings. However, before the role of these stabilization devices become formalized, more data on the indication for fusion versus decompression alone for patients with lumbar stenosis and spondylolisthesis will likely be needed. Finally, lumbar stenosis attributed to a synovial cyst is a topic of some controversy. Synovial cysts are believed to be responsible for the neurological symptoms of just over 2% of patients with lumbar spinal stenosis. They're found most frequently at the L4-5 level. Some suggest that a synovial cyst should represent an indication for upfront spinal fusion after decompression in a young patient, as it is a harbinger for segmental instability and thus represents an increased risk of recurrence. However, the data available does not really support this. It has been found that recurrence rates at the same level after decompression alone are low, and thus decompression should be the initial operative management choice for a patient with lumbar stenosis secondary to a synovial cyst. So, in conclusion, non-operative management is appropriate as an initial consideration for the management of lumbar spinal stenosis. However, no specific modality has been reliably demonstrated to be efficacious, and conversion to surgery after a period of non-operative treatment is common. Surgical decompression has been shown to be associated with significant improvement in patient-reported outcomes. Standalone interspinous process distraction devices have not been shown to improve clinical outcomes compared with conventional decompression and appear to increase the risk of reoperation. Conversely, interlaminar stabilization devices may serve as a useful adjunct to conventional decompression of lumbar spinal stenosis and may limit the need for spinal fusion. However, further data will be needed to validate these findings. Finally, the role for fusion for patients with lumbar spinal stenosis and a low-grade spondylolisthesis remains an area of active controversy. Thank you for your attention.